Thank you very much. I want to thank the organizers of the meeting inviting me here today, and also to Tony Monroy from CMR Naviscan for making it possible for me to be here. I'm a breast surgeon in Allentown, and I've been in practice since 1975 when I finished my training, so I think that's 41 years now I've been doing this. You see the gray hair. So why am I here as a surgeon at an imaging meeting, a radiology meeting? Well, it's because we surgeons and radiologists serve a common purpose and have a common goal, and that is to take better care of our patients. And so we work together, we work collaboratively, because in the end, we want to have a better result for our patients. And that's what I decided in the early part of my career. The first 20 years, I was a general surgeon doing all types of surgery, including breast surgery. But since 1995, I dedicated my practice just solely to breast surgery and care of the breast cancer patient. And so that allowed me to work more with industry, help develop products and devices and imaging that can better help our patients and help us take better care of them. About 10 years ago, I had the opportunity to move my private clinical surgery practice into a new facility, a brand new building. And in that building, I was able to go ahead and bring in our breast clinical practice, but my dream has always been to have everything under one roof for the patient. And so I actually brought together a group of radiologists, an imaging director, and we built a breast imaging center. Can you imagine a surgeon building a breast imaging center? Well, maybe I was crazy, but it worked out very well. And we had, since the last 10 years now, we've had digital mammography, breast ultrasound, breast MRI, capability for doing stereotactic breast biopsy on a prone table. We brought in a DEXA scanner too because of women's issues with women's imaging also. And we had that all under one roof, all together in one place. About 8 years ago, I was introduced to the idea of PET mammography, or PET scanning of the breast. And I was intrigued by it, and I learned more about it, and I spoke with our radiologist, and we all decided it would be a good addition to help us in problem solving with the patients where we had some confusing information based on mammogram, ultrasound, breast MRI, and clinical evaluation. And so I've had experience using the PET mammogram for the past 8 years along with our radiologists. And so I want to share some of my experience with you and why we find it helpful and some of the reasons that we do use it. So we know that breast PET evolved from whole body PET imaging. It was an outgrowth from that. And whole body PET imaging is great for what it's intended for, but it really wasn't optimal to evaluate the breast because of obvious limitations. The inability to identify lesions which were greater, or rather less than 5 millimeter, just doesn't have the resolution. Inadequate camera technology, suboptimal patient positioning, and so on. Interference from adjacent tissue activity, large dead spaces, and increased breast thickness. Am I going too fast for the translation? Are we okay? Okay, slow down a little bit, she says, okay. Because if I'm listening and talking, I get too confused. You know, I'm a man, I can only do one task at a time. I can't do the multitasking. So the breast PET really evolved as a solution to these problems shown above and improved the spatial resolution. And so we were able to detect lesions as small as 1.5, 1.6 millimeter, including DCIS and invasive breast cancer. So really, whole body PET was used, could only see a single lesion in the breast because of its resolution, where breast PET, improved resolution, could find more lesions because of its greater discernibility. So why high resolution breast BT? Why can we find more breast cancers? Well, when we take a look at how we do imaging of the breast with mammogram and MRI and then high resolution PET, we can see that the earliest detection with MRI really requires capillary growth because it's a vascular, it's a blood flow study really. That's what MRI is doing with gadolinium, of course. Not just looking at the anatomy, but looking at the uptake, the dynamic portion of the MRI. So we always use gadolinium with breast MRI, of course, for obvious reasons. But it depends upon the development of neovascularization. Whereas if we go ahead and look at something with a PET mammogram, we really see very early detection of small lesions because we're using interstitial diffusion. No capillary growth is needed. We're looking at metabolism of breast cancer itself, the higher metabolic rate of breast cancer incorporating the FDG, and that's how we differentiate things with any PET scanning, and specifically for PET mammogram, so we don't have to rely upon the development of neovascularization. PEM is also 3D. It's like 3D tomosynthesis with mammography nowadays. We can reconstruct the breast with 12 tomo slices, so we get a very good depiction in both the CC view and the ML view of the breast with these 12 slices, if you will. So we get a very good idea of what the breast looks like. So what are the clinical indications, as far as I'm concerned, for using PET mammography? Well, as we heard before, we have problems with the dense breast tissue, not only with mammography, but even when we use breast MRI to try to figure out what's going on in the mammographically dense breast tissue, we can have MRI dense breast tissue, and it's hard to identify. And as we heard in the previous talk, that breast density in and of itself is a risk factor for the development of breast cancer. So these people need increased screening beyond recommendations of annual mammography. And what can we do? Well, we can incorporate technologies which will give us better identification of abnormalities in dense breast tissue, because PET scanning sees through dense breast tissue. It slices right through it. The other thing that was mentioned, similar to the talk you just heard on MRI, is for surgical planning. So when I go ahead and do an image-guided biopsy, or the radiologist does the biopsy, and we have that report coming back, and it looks as if we have a single lesion in the breast, before we go to the operating room, especially for the patient who wants to have a lumpectomy, I go ahead and order additional advanced imaging to see if we have unifocal or multifocal disease. And we find in a certain percentage of time that we have additional lesions, and we can identify those very nicely with PET imaging of the breast. In our center, I have the luxury of having MRI and breast PET. So oftentimes I'll do both, because if I see a patient who has what appears to be unifocal lesion in the breast, and I have an MRI which shows single lesion and the PET mammogram showing a single lesion, I feel extremely confident we can do a lumpectomy and have clean margins on that patient, not leaving multifocal disease. But if either the MRI or the PET shows multifocal disease, then we have to have a discussion with the patient about doing a wider excision, or perhaps biopsying those other areas which are suspicious, and the patient therefore is no longer a candidate for lumpectomy, but rather mastectomy. The other reasons we use PET mammogram is in the neoadjuvant setting, just like you heard about MRI. And it's very nice to get the PET imaging on that patient before they start neoadjuvant chemotherapy and during neoadjuvant chemotherapy to monitor response. It's very patient-friendly compared to doing breast MRI. The other reason we use it is suspicion for recurrence. We do follow-up in our patients. When I see my patients, and I follow them every 6 months for the first 5 years, and then annually thereafter, I like to get both mammogram and advanced imaging. And I'll usually alternate. 1 year I do the MRI, and then 1 year or 6 months later I'll do the PET scan of the breast. So we're always alternating those, so we have the benefit of having mammogram plus advanced imaging on that patient on annual interval to pick up early recurrence. You heard about MRI for implant evaluation. The same thing is true with PET mammography. The other patients that should undergo screening with advanced imaging such as PET are those in the high-risk category. You heard about patients earlier today who have ductal hyperplasia or atypical ductal hyperplasia. And as the slide showed, using the Tyrer-Cuzick risk assessment model, almost any patient who has ADH, you plug that into the Tyrer-Cuzick formula, and you'll find the patient has greater than a 20% lifetime risk of breast cancer. It's almost automatic. Sometimes I don't even run the Tyrer-Cuzick. If they have ADH, I know the answer is going to be greater than 20% lifetime risk. So in those patients, they need additional imaging beyond mammogram. And I prefer to go ahead and get MRI at this point simply because in the States, in the US, we can't do a PET mammogram without a prior established diagnosis of breast cancer. We can't really use it for screening, but I wish we could, and I think someday we will be able to use it for screening in the patient not yet diagnosed with breast cancer because of its sensitivity and specificity, which I'll show you in just a little bit. And even in the patients who are recommended to have MRI because of increased risk or other factors, many patients cannot tolerate having MRI. We know at least 15% of patient population who we would like to get an MRI can't tolerate it for either weight restriction, anxiety, claustrophobia, implants, and so on. So these patients are ideal to have PET mammography. It's interesting, in my patients who have had both PET mammogram and MRI, I'll ask them, which do you prefer? Or if we could only do one, which would you have? And this is from the patients. 99% of the time, they say, definitely the PET mammogram. But maybe 1% of the time, a patient will say, no, I think the MRI was so much easier. I don't understand why they say that. But 99% will say they would much prefer having the PET mammogram as opposed to the breast MRI. I talked about lymph nodes. That's obvious, too, to look for adenopathy in the patient newly diagnosed. So let's talk about this. Dense breast on mammogram, an example you've seen before, 42-year-old patient, BRCA mutation, claustrophobic. She really can't tolerate MRI, but we go ahead and get the PET mammogram, very easily identified breast cancer. And you can see how easily the PET scan cuts through the dense breast tissue. This is a patient with screening mammogram, one area of increased density in the left breast, inferior. Ultrasound did show a lesion, biopsy revealed cancer. MRI did show one cancer in the left breast only. But the high-resolution PET found 3 lesions. We found lesions in the left breast and also a lesion in the right breast. So it's tremendously helpful to have this information for treatment planning. Again, another example, surgical planning after diagnosis. A biopsy-proven breast cancer. The breast PET was recommended for pre-surgical planning. And we see in this patient, not only do we have the lesion in the breast, we have multifocal disease and also an abnormal lymph node in the axilla. This is very important information because now when I take this patient to the operating room to do a sentinel lymph node biopsy, I'm expecting to have a positive lymph node. If that lymph node is negative, I have to think very much, is that falsely negative on that patient? Because it's so suspicious on the PET scan, the positive lymph node. The other interesting thing about the PET scan, it's looking at the cancer, not the microcalcifications which are associated with the cancer. So this patient had a mammogram that showed extensive calcifications. A biopsy was done which showed DCIS. And because of the extent of the calcifications, it was recommended to do a large segmentectomy. But the high-resolution PET scan showed only a small area of actual cancer. So this will allow a smaller lumpectomy to be done with clean margins. Because the goal in doing a lumpectomy for breast cancer with microcalcifications and diagnosed with DCIS is not to remove all the area of microcalcifications in the breast. It's to remove the cancer. So we're not so concerned about every last bit of microcalcification, but rather the cancer. So the PET mammogram can tailor our surgical approach. Another patient post-diagnosis, looking at a single lesion, but we got the PET mammogram, find a second lesion. So there's more and more of these examples. Mammogram you see here on the left, the PET mammogram not only shows the index lesion, but also shows the unsuspected second lesion in the breast. You know, I wonder sometimes when in the past, we operate on patient unifocal disease, we think is unifocal, we operate, we remove it, 2 or 3 years later, the patient has a recurrence. I'm not so sure it's a recurrence. I think maybe it was an unrecognized additional breast cancer at the time, which became manifest over the next few years. Monitoring response to adjuvant chemotherapy, we get it before we start with a CC MLO view. This is after a short period of time. Within a week or 2, we can see the resolution already about a week later, and then on 2 weeks later, we see again resolution. So we know our neoadjuvant chemotherapy is being effective. We don't have to change course. How about suspicion of recurrence? Here's a patient that came from Kathy Schilling, our colleague in Miami, where she has a patient who she was following for breast cancer, and it showed the patient had a new breast cancer in the contralateral breast about 12 years from her index cancer in the left breast, but was not found on the mammogram, but found on the PET scan, was a recurrent papillary cancer in the breast that she had treated 12 years previously. Implant evaluation. You've seen with MRI evaluating implants. Patient presented who had implants with some palpable masses in the breast. The breast PET was used for further evaluation, not only showing the 3 cancers in that breast, but axillary adenopathy. And this is a large group of patients that we use PET scan on. The high risk I referred to before, but unable to undergo breast MRI. This is a high-risk patient with dense breast tissue, a BRCA mutation. Breast PET was recommended, and here again you can see that cancer showing up very nicely. Why do we want to use assessment of the axillary lymph nodes in patients with breast cancer? Well, that determines what we do at surgery. Do we just do a sentinel node biopsy, or are we going to commit to an axillary dissection? So the breast PET can really show up the positive lymph nodes very nicely. Here's a patient who had a small index lesion on MRI, biopsy proven, but the PET scan showed 2 lesions adjacent to one another. We can still do a lumpectomy around this patient here, but we also notice that there's a probable metastatic axillary lymph node. Again, another example of showing how the PET scan alters our treatment at surgery, or alters our approach at surgery. Index cancer, unsuspected axillary lymph nodes. This is why we do advanced imaging. And again, another example. Well, let's compare PEM to MRI. Well, we know, as I mentioned before, breast MRI is not tolerated by approximately 15% of patients. So this pie graph shows why. This is the total of the 15%. Of the 15%, we have 11 of those 15% are due to claustrophobia. They can't or won't have an MRI. 3% were medically intolerant MRI, and 1% due to gadolinium restrictions related to risk. In other words, patients who have renal failure or impaired renal function, we can't use gadolinium on those patients who have a reduced GFR. So these patients, we want an alternative, and this is where the PEM comes in very nicely for these patients. So it's more comfortable to have the breast PET done for the patient. They're sitting in a position as if they would be having a mammogram. If a biopsy is necessary, it can be done the same day. There's the 12 images. Well, it's 12 images for each view, so it's really a 12 cc, 12 MLO, and then you do the same on the other breast. For MRI, of course, patients can have, many do have claustrophobia, as I mentioned before. Biopsy usually can't be scheduled on the same day. They have to come back to have the biopsy done, and you have a lot more images to look at. You can confirm adequate sampling with a PET scan, and I'll show that in just a minute. Now, I'm not going to go over all of these, lack of time, but there's many studies showing the sensitivity and specificity of PET mammography being as good as, if not better, than breast MRI. Basically, the sensitivity is about the same as MRI, but the specificity is higher in most studies. And of course, this has matured over time. Initially, you're going to have a lower specificity when a new imaging modality comes around because of the inexperience of the people who are interpreting it. We don't want to miss anything, so we're more likely to call things that with more experience you're not going to call. So it's just natural over time, the specificity of any type of imaging or any new test is going to increase over time. And that's true with PET mammography now. We have sensitivities in the 90s to high 90s, specificities also in the low 90s to mid 90s. Again, not go over all these studies for you to bore you with those. If we compare conventional modalities, pros and cons of mammography, 3D mammogram or breast tomosynthesis, breast MRI, breast ultrasound, contrast-enhanced mammography, and high-resolution breast PET, we can compare all the pros and cons. Basically, in summary, when we look at all this very busy slide, we find that the high-resolution PET really has a lot of advantages over these other modalities. Some of the cons is that the patient has to sit for the soak time, like any PET scan, has to sit for an hour, and then has the study done following that. We can't use it in diabetic patients who have high sugar levels, again, just like whole body PET CT scan. So the advantages of breast PT, I'm almost finishing up now, has the comparable sensitivity to MRI, higher specificity, I already mentioned that, and the big important thing with breast PET, it's not affected by the menstrual cycle of the patient. And because it's not dependent upon that, it's dependent upon glucose utilization of the tumor cells, not blood flow in a busy breast based on menstrual cycle variation. And it's not affected by breast density, not affected by the tumor type. So these are all the tremendous advantages that we have with breast PET. and breast PET is rather specific. Here's an MRI showing a cancer in this breast, the one on the left, and also what was felt to be a breast cancer in the opposite breast. But the PET scan did not show a lesion on that side. Biopsy was performed and proved that it was benign, where the MRI gave us a false positive. So the breast PET really gave us a true negative in this example. It's rather easy to interpret the PET. Our radiologists really enjoyed looking at these. They found it much easier to interpret than breast MRI. And again, not affected by hormone. Look at this very busy MRI. That's a nightmare for a radiologist to read an MRI like that because of so much uptake in that breast and because of the hormonal situation for that patient. But the breast PET clearly cuts through all of that. Breast PET biopsy, this is Dr. Kathy Schilling from Miami. Some of you may know her, an excellent radiologist who has developed a very nice technique of performing the biopsy with the patient under the PET mammography itself. The patient's upright. It's easier than MRI as far as tolerance in the position that they're in, and of course no claustrophobia. What's done is the target is visualized with the PET scan, and then the fiduciary is placed into the breast. The scan again is repeated, showing correct positioning of the fiduciary. And this is the cannula through which the biopsy device will go. Sampling is confirmed, just like sampling with MRI or stereotactic or ultrasound using a vacuum-assisted device. And the very nice thing is, once the samples are obtained, we do a PET image of the samples, and you can see the uptake in the samples. You can't do this with MRI. You just hope, keep your fingers crossed, hope you've sampled the correct lesion, wait for the pathology report, and do follow-up. So this is very nice that it confirms you have the area of interest. It's similar to doing a stereotactic biopsy for microcalcifications. You take an X-ray of the specimen, you see the microcalcifications, you know you've gotten the correct lesion. Same thing is true with the breast PET. Thank you very much.